Hello, and welcome to the NJIN NJDOH September webinar, Positive Approaches for Managing Vaccination Fears and Misinformation. Presentation today will be presented by Jennifer Smith and Jenish Sudhakaran. Jenish Sudhakaran is a Population Assessment Coordinator for the Vaccine Preventable Disease Program at the New Jersey Department of Health. In this role, Ms. Sudhakaran responsibilities include identifying and monitoring pockets of under-immunized children in New Jersey schools by using coverage estimates through the utilization of assessments and surveys. She is a resident expert on the New Jersey State Sanitary Code for pupils in school and institutions of higher education, hospital rules, and the Childhood Immunization Insurance Law. She collaborates with the key stakeholders to promote timely immunizations and address vaccine safety concerns. Ms. Sudhakaran is a graduate of Pennsylvania State University with a Bachelor's of Science in Exercise Physiology. She received her Master's of Public Health with an emphasis in health systems and policy from the University of Medicine and Dentistry of New Jersey in May 2008. Jennifer Smith is the health educator for the Vaccine Preventable Disease Program at the New Jersey Department of Health. In her role, Ms. Smith selects and develops appropriate immunization educational materials for use by the public and healthcare providers. She facilitates meetings or special events to increase immunization awareness and serves as the VPDP liaison with the department's Office of Communication. Ms. Smith obtained her Master's in Public Health with an emphasis on health education and behavioral science from the Rutgers School of Public Health and is a certified health education specialist. Most recently, she received the Louis Schutt Award for Program Excellence from the New Jersey Society for Public Health Education for her work on a childhood immunization program. Ms. Smith values long-term learning and having the opportunity to collaborate with others on important health initiatives. So before we get started, I want to point out a couple of housekeeping rules today. The webinar itself will last approximately 1 hour and 15 minutes. All attendees will be muted throughout the webinar. If you have questions, please submit them through the Q&A box on the webinar control panel, which is located at the top or bottom of your screen. Any questions remaining unanswered at the end of the webinar will be compiled and the answers provided to participants a few days following the webinar. The webinar is being recorded and will be made available on the New Jersey Immunization Network website. Accreditation statements include the following. This activity has been planned and implemented in accordance with the essentials area and policies of the American Nurses Credentialing Centers, Commission on Accreditation, and New Jersey State Nurses Association through Health Research and Education Trust of New Jersey in joint providership with the New Jersey chapter, American Academy of Pediatrics. Health Research and Education Trust is an approved provider of continuing nursing education by the New Jersey State Accreditation and accredited approver by the American Nurses Credentialing Centers Commission on Accreditation, number P131-2/18-21. This activity provides 1.25 contact hours. Successful completion of the course is defined as in-person attendance for 90%, 95% of the didactic learning session, and a complete course evaluation. There are no relevant disclosures or conflicts of interest. There are no sponsorships or financial commercial support being supplied for by this activity. Accredited status does not imply endorsement by the provider or the American Nurses Credentialing Centers Commission on Accreditation of any commercial products displayed in conjunction with this activity. An application also has been submitted to the Certified Health CHES statement for Certified Health Education Specialists up to 1 total hour of continuing education contact hours. The Rutgers Office of Public Health Practice is a designated multiple event provider of CHES by the National Commission for Health Education Credentialing. And lastly, this activity has been planned and implemented in accordance with the accreditation requirements of the Medical Society of New Jersey through a joint providership of Atlantic Health Systems and the New Jersey Chapter American Academy of Pediatrics. Atlantic Health System designates this large education activity for a maximum of 1.25 AMA PR Category 1 credit on date. Physicians should claim credits commensurate with the extent of their participation in this activity, Atlantic Health System is accredited by the Medical Society of New Jersey to provide continuing medical education credits. So we have today's presenters. Of course, we'll begin with Dr. Paul Offit. We'll move to Jenish Sudhakaran, and lastly to Jennifer Smith. Our learning objectives today are as follows: to develop effective vaccine communication messages, develop strategies for building trust between clinicians and parents, and to be able to share credible vaccine information resources. So without any further delay, I would like to introduce Dr. Paul Offit.
Thanks, Michael. I think the issue of vaccine hesitancy or vaccine denial has become more and more important. So I think this is something that people on the front lines are going to be dealing with, unfortunately, every day. So let's talk about that. I think that you can divide people who are concerned about vaccines into two groups. The first group I would reasonably label as vaccine hesitant. They've smelled the smoke. They want to know whether there's any fire there. They are reassurable. I think if the information is presented to them in a passionate, compassionate, and compelling manner. And it's understandable. I mean, we ask parents today to get 14 different vaccines in the first few years of life. That can mean as many as 26 inoculations during that time. It can mean as many as 5 shots at one time to prevent diseases most people don't see, using biological fluids most people don't understand. So I think we need to re-explain ourselves. I mean, my parents were children of the 20s and 30s. They saw diphtheria as a common killer of teenagers. They saw polio as a crippler. I was a child of the 50s and 60s. I had measles, mumps, German measles, or rubella, chickenpox. So I know what all those diseases felt like. So it was easy for me to know how important it was to vaccinate my children. But parents today, young parents today in their 20s, even frankly young doctors today, are far less compelled by diseases because they don't see those diseases. And I think for that reason, we need to understand how vaccine safety becomes much more important issue than vaccine effectiveness when you don't see these diseases as commonly. The second group of people, I think, can more reasonably be described not as vaccine skeptics, which often they will claim. They are more reasonably called vaccine cynics, because when presented with information, the right kinds of information that answers the questions, such as do vaccines cause autism, they just don't believe it. They believe that there's a conspiracy to sell vaccines, that the pharmaceutical industry is at the center of that conspiracy, that data are misrepresented or worse, falsified, and that they just don't believe it. And I think that it's very difficult, I think, to try and convince conspiracy theorists that they're wrong. So I think that's where the rubber meets the road in that particular situation, frankly, I think is the law. And that's what's happened in Southern California, for example, when there was an outbreak in 2014, 2015. They then became aware of the fact that it was important to compel people to get vaccinated, even if it wasn't something that they wanted to do. And so California became the third state to basically eliminate all non-medical exemptions. 2 more states have subsequently followed, Maine and New York, and maybe that's the trend. We now have 5 states that only allow for medical exemptions. So sadly, I think sometimes people have to be compelled to do the right thing by law when there is simply no way that one can use reason or logic to compel them. Good luck. We're counting on you out there. Thank you.
Thank you, Dr. Offit. This time, I'd like to turn the presentation over to Jenish Sudhakaran.
Thank you, Michael. From Dr. Offit's presentation, we see that vaccine hesitancy has been in existence for a long time and is not going away anytime soon. Vaccine hesitant parents can be reassured if information is presented to them in a compassionate, passionate, and compelling manner. Providing a strong recommendation to vaccinate isn't enough. We need to incorporate mindfulness and a positive attitude with our approach. As clinicians, this means attending to what the patient is talking about rather than jumping in and taking over with suggestions, instructions, or judgments. So consider your actions, be aware of your body language and your level of interaction with patients. Although you may be communicating the right messages, is your body language showing something else? Having a positive approach and practicing mindfulness can help to decrease the unintended consequences of parents choosing not to vaccinate. So how many parents do you think are choosing not to vaccinate? I'm going to launch 2 poll questions. The first question is, what percentage of parents refused all recommended vaccines for their child? The polls will be open for 15 seconds. Please select the best answer. I see the majority of you have responded 10%, but the actual answer is B, 3%. A national survey in 2010 of parents with children under 2 years found that 3% refused all vaccines. The next poll question is, what percentage of parents do you think refused at least one recommended vaccine for their child? Again, you will have 15 seconds. I see it's a very close tie between 25% and 19.4%, but the actual answer is C, 19.4% had refused or delayed at least one recommended vaccine. I wanted to point out that these numbers are higher in certain communities, especially in states that have laws allowing more exemptions. Although exemptions vary from state to state, all school immunization laws grant exemptions to children for medical reasons. There are 45 states and Washington, D.C. that grant religious exemptions for people who have religious objections to immunizations. And currently, 15 states allow philosophical exemptions for those who object to immunizations because of personal, moral, or other beliefs. In New Jersey, there are only 2 allowable exemptions, medical and religious. Philosophical, moral, or conscientious objections are not acceptable. In the next few slides, I will discuss some data providing a broader picture of New Jersey's immunization landscape. The increase in religious and non-medical exemptions throughout the country continues to worry public health officials and healthcare providers because herd immunity may become compromised, leaving schools and communities with low vaccination rates vulnerable to outbreaks of vaccine-preventable diseases. To put these exemptions in the context of New Jersey, there has been an overall increase in religious exemption rates across the board in all grades that were assessed through the annual immunization status report over the past 13 years. As you can see, prior to 2008, the New Jersey's religious exemption and medical exemption rates remained relatively low. However, in 2008, with the broadening of the religious exemption rule and the addition of 4 new vaccine requirements, flu and pneumococcal vaccine for childcare and preschool facilities, and Tdap and meningococcal vaccines for 6th grade, we noticed the exemption rates began to increase. In 2018, the religious exemption rate was at 2.6%, and we have seen a relatively consistent numbers between 0 and 1% for reported medical exemptions. In 2018, the medical exemption rate was at 0.2%. This slide focuses on medical and religious exemptions. The next slide will show how exemptions can impact immunization coverage rates. Shown here are the 2018-2019 coverage and exemption rates for all reported grades and county collected in the annual immunization status report. The data on this slide is showing counties in the order of lowest to highest immunization coverage rates, which vary from 92.7% to 96.7%. The state average is 94.2%, highlighted with the red box. The blue bar represents percent of children meeting all immunization requirements. The orange bar represents percent of children admitted provisionally. The gray bar illustrates the percent of children with religious exemptions, and the yellow bar represents the percent of children with medical exemptions. As I mentioned, this data has been collected for New Jersey schools. All of the New Jersey school data is available on the Vaccine Preventable Disease Program webpage, which is listed on the resource slide at the end of the presentation. On the next slide, we will take another step back to look at childhood immunization rates as compared to national averages. This graph illustrates trends in immunization coverage rates for the 431-3314 series in New Jersey, shown in blue, and nationally, shown in orange, for children 19 to 35 months of age from 2009 through 2017, according to the Centers for Disease Control and Prevention National Immunization Survey, or NIS. The Healthy New Jersey Healthy People 2020 target is in green. This vaccine series consists of 4 or more doses of DTaP, 3 or more doses of polio, 1 or more doses of MMR, 3 or 4 doses of Hib, depending on vaccine type, 3 or more doses of hepatitis B, 1 or more doses of varicella, and 4 or more doses of pneumococcal conjugate vaccine. According to 2017 NIST, New Jersey coverage rates for the 431-3314 series by 19 to 35 months of age is 69.3%. National coverage is 70.4%. Since 2009, New Jersey has continued making progress towards the 80% healthy people 2020 target. There was a statistically significant increase for this series from 2010 to 2017. Some of the fluctuations we see on a year-to-year basis may be attributed to smaller sample size and larger confidence intervals. This slide and the previous slide focus on the school requirements in primary series as a whole. Next, we will take a look by individual antigens. So if we break the series down by antigen, we see some slight variances in coverage. We can also see New Jersey's current vaccination coverage in comparison to the United States and Healthy New Jersey and Healthy People 2020 objectives. New Jersey is represented by the red bars, and US is represented by the blue bars. In this graph, the Healthy People targets are represented in green and Healthy New Jersey targets in purple. For each antigen in the primary series, we are similar to the national average. As far as New Jersey's progress towards meeting Healthy People 2020, New Jersey is close to reaching or has reached the target of 90% for polio, MMR, hepatitis B, and varicella. The reason for why DTaP, Hib, and pneumococcal conjugate vaccine have lower coverage rates is because each of these vaccines are part of a multi-dose series, which require the last doses to be administered on or after 12 months of age. So if any of those doses are not given at the recommended time frame, it can result in a domino effect, which ultimately delays the remaining doses to later ages, which is where we start seeing a drop-off in clinical visits. Reducing missed opportunities would promote timely receipt of all recommended vaccine doses and decrease the amount of time that children remain vulnerable to vaccine-preventable diseases. Lastly, we aren't limited to just childhood vaccines, so the last graph I will show you presents data for adolescents. For adolescent immunizations, missed opportunities are key, especially with the HPV vaccine, which is one of our biggest challenges and is often the most concerning to parents and clinicians alike. This is a summary slide of adolescent vaccines broken down by antigens compared to the Healthy People 2020 objective according to the NIST Teen Survey. New Jersey is represented by blue bars and US is represented by gray bars. The Healthy People target is shown in orange. The men ACWI rates and Tdap rates for dose 1 are higher than the first dose of HPV vaccine and surpass the Healthy People target of 80%. But keep in mind that New Jersey mandates both Tdap and meningococcal vaccines for 6th grade and higher. As you can see, there are a lot of different vaccines that are recommended throughout the lifespan. As noted by Dr. Offit, the number of vaccines listed in the recommended schedule is a top concern for parents. Remember, it is important for clinicians to reinforce the following. Parents who are worried about the increasing number of recommended vaccines should take comfort in knowing that children are exposed to fewer antigens today than any time in the past. Every day, infants are exposed to a far greater number of antigens than those found in vaccines. We have already addressed some of the common parental concerns, but what are other concerns you are hearing in your practice? I'm going to launch another poll question. Please select the best answer that applies. Okay, I see that majority of you selected E, and you are correct. All of the above are reasons that may contribute to vaccine hesitancy. What is important to remember is that we will not be able to reach everyone. There will always be cynics or refusers, but we should be focusing on those who are the fence sitters, so to speak, those who have questions and concerns that we just may need to take some time to address. Let's see how one pediatrician communicates with a vaccine hesitant parent in his practice.
Hello, Jenish. Nice to see you again. Mrs. Smith, nice to see you. So all the vital signs, everything looks terrific. So we're happy about that. So we'll get on with the business at hand today. You're due for 3 vaccines today. We're going to do the meningococcal, we're going to do the HPV, and we're going to do Tdap. Do you have any questions about those?
I think my mom did have some concerns about the HPV vaccine. Yeah, so I had seen on some social media posts from friends of Denise's that.
Yeah, so let me stop you for a second. So we commonly get those kind of things in the office. Something that I hear every day. And what I can tell you is this is what we do. We give vaccines, and we've been doing it for a long time. And so the information that might be scaring you away from these is just not the real information. So it would be my suggestion that we go ahead and do these vaccines today.
But I had also seen a TV segment on a morning show that also was talking about how it could HPV vaccine could lead to infertility. So I'm just kind of worried about is that going to happen?
I hear that, and again, it's not a story that we're unfamiliar with when we have people coming in and having concerns. But really, it's the reverse that's true. So with the cervical cancers, that could lead to infertility. The HPV is to prevent that from happening.
I just think I'm going to need more time to think about it.
Okay, well that's fine. Again, we're kind of the experts in this, and I would hope that you would reconsider. But go on from there.
As you can see, how you communicate with your families drives the vaccine decision-making process. Now I am going to hand over the presentation to Jennifer, who will be speaking about communication techniques. Jennifer?
Thank you, Jenny. Although the provider recommended the HPV vaccine and answered the parent's question about fertility, did you notice opportunities for improvement? When the parent mentioned social media, the doctor interrupted her because he already knew what she was going to say, when really he was just assuming he knew her concerns. Did you also notice that he referred to himself and the practice as experts? Just note that this could come across as being a little condescending to some. All in all, it won't always be a perfect interaction, but with a little practice, we can all improve our communication with patients. This slide shows that there are many factors that come into play when addressing immunization concerns. Immunization is a complex communication environment. As concern for vaccine-preventable disease grows, usually in the setting of an outbreak, vaccination rates similarly improve. Likewise, as rates of vaccine-preventable diseases dwindle, caregivers may grow to fear the vaccine more than the disease it prevents, thus leading to decreased vaccination rates. Low disease awareness often leads to increased focus on vaccine risks. This is compounded by a full and complicated immunization schedule, which Dr. Offit mentioned in his presentation. In addition, there is limited time for discussion in provider offices, and there are a multitude of places where parents can access information, all of which is not reliable. In the role play, we saw a classic example of vaccine hesitancy. We've been mentioning this term, but what does it exactly mean? The World Health Organization, or WHO, defines it as a behavior influenced by a number of factors, including issues of confidence, complacency, and convenience. Vaccine-hesitant individuals are a heterogeneous group who hold varying degrees of indecision about specific vaccines or about vaccinations in general. Vaccine-hesitant individuals may accept all vaccines but remain concerned about them. They may refuse or delay some vaccines but accept others, or they may refuse all vaccines. The skeptics, or the group refusing all vaccines, as previously stated, is estimated to be approximately 3% of parents. Rather than focusing on the skeptics, the bulk of our effort should be with the vaccine-hesitant population, since this group may be more amenable to interventions. We probably have all come across some resistance from the public when trying to communicate the benefits of vaccination. Are vaccines safe? Are they necessary? What are the ingredients? All of these are fairly common questions. Fear of vaccines is not new. Smallpox vaccine, the first successful vaccine to be developed, was introduced by Edward Jenner in 1796. He observed that milkmaids who had previously caught cowpox did not later catch smallpox by showing that inoculated cowpox protected against inoculated smallpox. As you see on this slide, the cartoon is a caricature of a smallpox inoculation. On the left, the poor are brought in with free food. Then they are inoculated and sprout cow parts. The doctors look severe and unfeeling, and the vaccination itself appears harsh and bloody. The woman in the center receiving the vaccine appears frightened, though unaware of the people behind her growing cows from their appendages. Many people did not trust this new technology, doubting its safety and worrying about a conspiracy from doctors or the government. Still, every year, greater numbers of people were vaccinated under this new method, which became the basis for modern vaccination practices today. Because of widespread vaccination, smallpox was officially eradicated in 1980. Although the cartoon is from 1804, it depicts similar fears and misinformation we see surrounding vaccinations today. There's no single intervention that addresses all instances of vaccine hesitancy, but today we're going to focus on some evidence-informed best practices for clinicians to increase vaccine acceptance through skilled conversation about vaccination. But before we discuss these communication strategies, what has research with healthcare professionals and parents demonstrated thus far? According to research from the Centers for Disease Control and Prevention, or the CDC, there's a strong support from healthcare providers for the existing immunization schedule. Most children are getting immunized. These discussions are just taking a little longer than in the past. Although some providers would like to postpone the vaccination conversation, the best strategy is to start the conversation early. Normalize vaccination as a part of the patient's pregnancy care. Hearing vaccination recommendations from obstetricians, gynecologists, pediatricians, and other healthcare professionals helps to reinforce the message. These conversations provide an opportunity for clinicians and parents to build mutual respect and trust. Also, it's great to provide educational materials in your practice, but remember, these should supplement, not replace, conversations between healthcare professionals and parents or caregivers. Regarding research with parents, there's a spectrum of parental attitudes, beliefs, and behaviors requiring some tailoring and layering of communication practices and materials. The majority of parents are confident in vaccine safety. Many parents have at least some questions or concerns, but just because they have questions does not mean they're going to refuse vaccines. Questions and concerns do not always equal lack of confidence. Keep in mind, social influences can impact parents' attitudes and opinions. And facts don't always speak for themselves. Personal accounts can be more persuasive and memorable. The risk communication approach is needed to maintain trust, and I will discuss this more in the next upcoming slides. The great news is that parents trust healthcare providers. A strong recommendation from a healthcare provider is the single best predictor of vaccination. Personal stories, supported by educational resources about vaccine-preventable diseases, are well received and strengthen the family-doctor relationship. Parents should be hearing positive vaccine messaging from all your staff members. Repeated messaging can help build trust and confidence in vaccines and will aid in their decision-making process. One thing you want to avoid is shaming a family on their decision not to vaccinate. Shaming will erode the family's trust and respect. We often see extreme examples of this in the media. This article, titled "Don't Call Them Dumb: Experts on Fighting the Anti-Vaccine Movement," describes how the measles outbreak in 2015 led to outbursts on social media. As quoted on the slide, when you attack someone's values, they get defensive. It triggers an instinctive defensiveness that certainly doesn't change the mind of the vaccine hesitant person. Another quote I listed is from political scientist Dr. Brendan Nyhan. He stated, "I think this is important to point out because there's a tendency for us to just want to tell folks that they're wrong. We think by just giving them evidence or showing them the facts and evidence, we're going to change their mind, when in fact, the opposite can occur." A study conducted by Dr. Nyhan in 2014 concluded that pro-vaccine messages do not always work. The effectiveness of those messages may vary depending on existing parental attitudes. Nyhan conducted a survey with approximately 1,760 parents aged 18 years and older residing in the United States who have children in their household ages 17 years or younger. Parents were randomly assigned to receive one of four interventions. The first intervention was CDC information explaining the lack of evidence that MMR vaccine causes autism. The second intervention was textual information about the dangers of the diseases prevented by MMR. This information came from the vaccine information statement. The third intervention was images of children who have diseases prevented by MMR vaccine. And the fourth intervention was a CDC fact sheet containing a dramatic narrative about an infant who almost died from the disease. And finally, there was a control group which received none of the interventions. Well, none of the interventions increased parental intent to vaccinate a future child. Refuting claims of an MMR autism link successfully reduced misperceptions that vaccines cause autism, but nonetheless decreased intent to vaccinate among parents who had the least favorable vaccine attitudes. In addition, images of sick children increased expressed belief in a vaccine autism link, and a dramatic narrative about an infant in danger increased self-reported belief in serious vaccine side effects. This can be the result of something known as disconfirmation bias. When presented with information we don't want to hear, we try very hard to reject it. That is especially true for beliefs that are central to our identity. Simply correcting parents' knowledge gaps, whether through informational brochures, community campaigns, or direct provider conversations, is often not enough to address parents who have concerns. We need to improve vaccination by focusing on how people actually think. We need to know our audience. Health messages must be tested before dissemination to assess their effectiveness, especially among more resistant or skeptical populations. So in order for us to find out what can be some helpful strategies, let's discuss a phrase I mentioned: risk communication. Risk can be defined as the probability of loss of that which we value. Uncertainty about vaccine risks and benefits spurs the need for vaccine risk communication. Risk communication can be defined as a science-based approach for communicating effectively in high concern, high stress, emotionally charged, or controversial situations. I think we can all agree that vaccines fit the criteria. Risk communication is recognized as two-way and multi-directional communications and engagement with affected populations so that they can make informed decisions to protect themselves and their loved ones. It should utilize the most appropriate and trusted channels of communication and engagement. Now let's talk more about the risk in risk communication. Perception is reality, and risk perception is complex. It's influenced by many factors, including characteristics of the particular risk in question, biases and other factors, and emotion. Risk characteristics impact perception. For example, risks that are perceived to be familiar, voluntary, natural, or under an individual's control are more accepted than risks perceived to be unfamiliar, involuntary, or exotic. Let's use vaccines as an example. Individual versus system control. Parents who reluctantly get their children vaccinated only because it's required by school entry laws are more likely to think of vaccines as risky since the decision is not their own. They didn't feel like they had individual control. Natural versus manufactured. Some individuals who have alternative health beliefs may feel that vaccines are not natural but man-made and so pose a threat to their children's immune system. Since they view vaccines as unnatural, they see it as risky. Familiar versus unfamiliar. A vaccine that is familiar and has been around for a while may be perceived by some as being less risky than a new, less familiar vaccine. I remember this was a concern when H1N1 vaccine was first developed. Not memorable versus memorable. As anyone who has ever been around a child being vaccinated knows, people don't easily forget the visit to the doctor's office and how unhappy the young infant was after being vaccinated. That memory can make some perceive that vaccines are riskier than they actually are. And there are a number of biases that influence perception. For example, omission bias. This refers to our tendency to choose inaction over action in the face of risk decisions. Because of this bias, some may believe that it's easier and safer not to vaccinate their child than to risk vaccine side effects and pains from the vaccine. But the risks associated with not vaccinating children can be devastating. It could lead to children contracting the disease, and that they can suffer those symptoms and pass the disease along to siblings and friends. A popular example of omission bias would be Benjamin Franklin. He once was afraid of the vaccine side effects from smallpox, so he decided not to have his son vaccinated. Unfortunately, his son passed away from the smallpox disease. After the death of his son, he long regretted his decision not to vaccinate, and then he became a strong advocate for smallpox inoculation. Availability heuristic. This refers to our tendency to overestimate the likelihood of easy-to-imagine events. When examples or associations are easily brought to mind, this fact leads to an overestimation of the frequency or likelihood of the event. So people might overestimate the frequency of a vaccine adverse event if they can quickly call to mind examples of real or purported adverse events they've seen in the media or on the internet. And they may underestimate the frequency of vaccine preventable diseases if they don't see cases or hear about them. Expert bias. Those of us who work every day in immunizations may have a different point of view due to our training and expertise. And it's difficult for us to understand the public's fears and to put ourselves in their shoes. It's important for us to determine what parents are concerned about and not to dismiss or play down their fears or concerns. Then we need to translate what we know about the audience into appropriate messaging. Finally, emotion impacts risk perception. Health experts do not view the risks associated with a medical procedure, such as vaccination, in the same way as members of the public. What the experts or risk assessors mean by risk can be called hazard. What the public refers to as risk, meaning all the things that people are worried about, which the experts can tend to ignore, that could be called outrage. Experts understand risk in terms of numerical values and rates. This table on the slide compares the risks of death due to 3 vaccine preventable diseases and the risk of adverse events following immunizations with the approved vaccines. These numbers may not be so convincing to parents. In contrast to the perception of experts, parents would want to know whether they or their child could be the one in a million who develops encephalitis following immunization with measles vaccine, for example. Although a clinician may view a vaccine side effect as rare, a parent may view that side effect as a potential reality for their child. A parent's natural instinct is to protect their child, no matter how low the risk. If it happens to their child, that risk is magnified to 100% in their mind. There's a need for clinicians to develop empathy in order to communicate effectively and to practice what experts call outrage management. On the slide are some strategies for successful communication for outrage management. There's a common goal that we all share, and that's the health of the child. While all of the strategies are important, the top 3, listening, echoing what you heard, and finding that common ground, are imperative for laying the groundwork. Let's see what this looks like.
Good afternoon, Mrs. Smith. It's nice to see you again.
Good to see you.
Thank you. So I understand that your daughter is here for her varicella vaccination today, and I want to know if there are any questions that you have.
Yes, so actually I heard some parents in my daughter's classroom talking about having a chickenpox party where they get together and the children pass the chickenpox to each other, so it's natural infection rather than getting vaccinated and having some dangerous toxins introduced. So I was thinking about taking her and was wondering what you thought about it.
Well, it doesn't sound like fun to me, but nevertheless, I understand why you would raise that issue and concern and ask about it, and I appreciate you asking for my opinion on it, which is I believe that we should provide the vaccination. The reason predominantly being is that if we can prevent the child's exposure to that, we should take advantage of that. And really, we have a common cause here, and that is the health and wellness of your daughter. And if we can prevent her from having to experience some of the side effects of the virus itself, the disease, we should take advantage of that. While most of the times the ramifications of the varicella virus is light. Everybody is a little bit different in that instance, but it can have serious implications to it.
What kinds of serious complications could there be?
Well, so it varies from person to person. It could be dehydration, rashes on the skin, simple things that are not life-threatening, but it can also result in lung infections and pneumonia.
I didn't know that. When I had chickenpox, it was just a rash that had a couple bumps on my skin and I was fine. But, I just want to do what's best for my child.
And I congratulate you for that. And again, it's a common bond that we have in the care for your child. So my recommendation is let's just go ahead and do the immunization today.
Well, I trust your opinion, so I say let's get the shot.
Good, thank you.
The provider did a great job listening to the parents' concerns and explaining why vaccines are the better choice. Now let's take a moment for a quick poll. Which of the following do you think would be the best way to begin the vaccine conversation? You'll have 15 seconds. Answer choice B would be the best way to begin the vaccine conversation. It looks like most of people chose that. That's great. And the reason why is because the provider was using the presumptive approach. Studies have found that the presumptive approach to be more effective than the participatory or directing approaches. The presumptive approach presents the vaccine information in a manner that assumes parental consent. Johnny has some shots today. whereas the participatory approach invites a conversation in keeping with a model in which decisions are shared. What do you think about jogging shots today? A recent study by Opal and others found that among all parents, a much larger proportion resisted vaccine recommendations when providers used a participatory rather than a presumptive format. Additionally, the study found that almost half of parents who initially resisted vaccination later accepted the provider's initial recommendation if the provider continued to recommend it. So persistence is key. Finally, the directive approach, or the provider knows best tactic, can be ineffective. This style tends to dismiss parental concerns. Let's now see how one provider uses the presumptive approach to introduce HPV vaccine.
I think it's good to say it something like this. So today we have 3 vaccines for your child: the meningococcal vaccine, the HPV vaccine, and Tdap. What questions do you have for me? It's just a normal, natural part of the bunch. You're not going to have the HPV vaccine stand out, and you're going to make sure to include the word today so it gets across. We're going to do this all today. By giving the vaccine recommendation the same way and the same day, you're going to save time. So sometimes physicians say to me, well, I can't really talk about something around sex in front of an 11-year-old. It makes me feel so uncomfortable. Well, my answer to that is, did you explain fecal oral spread before you gave the polio vaccine? No, you did not. So the same with this. Just say, today we have 3 vaccines for you: Tdap, HPV, and meningococcal vaccine. It'll save you time, and you won't have to talk about sex.
That was a wonderful video. Another point I want to mention is that when you have limited time, try to get across your key messages, what your patients need to know more than anything else. Try to stick to 3 main points. Any more than that, and you risk that your message will be forgotten. Don't assume that parents aren't going to agree. You could be assuming something that isn't even the case. So maybe you use the presumptive approach and provide a strong recommendation, but the parent still has hesitation. They've heard some myths surrounding vaccination. Let's take a poll and see how you would handle that situation. I see overwhelmingly, oh no, I'm reading it incorrectly. The best answer choice would be D, okay? Both A and B are putting people in the defensive position. It's setting up an argumentative situation where each person tries to replace fact with fact. And regarding answer choice C, simply restating a myth hasn't been proven to be an effective strategy. Once people hear a myth or misinformation, it's very difficult to remove that from their minds. Debunking a myth can actually strengthen it, making myths more familiar by providing arguments that threatens one's worldview. This is most likely the reason why many myths seem to resist, because we hear them over and over again. So on this slide, I listed a few helpful tips for debunking myths. 1, focus on the facts that you really want to communicate. Any mention of a myth must be preceded by an explicit statement that the myth is false. 2, keep it simple. A simple myth is more cognitively attractive than an overcomplicated correction. These are where our key messages come in handy. And 3, when we debunk myths, we should also try to offer an alternative explanation for false beliefs to fill the gap left by misinformation. Let's go over a few common myths. On this slide is a possible response to a parent who may ask about vaccine side effects. You may also want to keep the following points in mind. Remind parents that most side effects are mild and go away within a few days. Reassure parents that you and your staff are prepared to deal with serious side effects if necessary. And encourage parents to watch for possible side effects. Provide information on how they should treat them and how to contact you if they observe something they're concerned about. This gives the parent some sense of control. In this scenario, the parent is asking about MMR and autism. Be sure to give the empathetic reassurance that you understand their infant's health is their top priority, and it's also your top priority. Share that the onset of autism symptoms often coincide with the timing of vaccines, but is not caused by vaccines. Just because events occur around the same time does not mean that one causes the other. Also, give your personal and professional opinion that vaccines are safe. You may get questions about a vaccine being relatively new. Be sure to acknowledge their fear, ask permission to share your opinion, and ultimately address the parent's concerns regarding safety. The CDC recommends using something called the SHARE method when recommending vaccines. So this is another tool you can use. If you were recommending the flu vaccine, you would, S is for share the reasons why flu vaccine is right for the patient given his or her age, health status, lifestyle, occupation, or other risk factors. H is for highlight positive experiences with flu vaccines to reinforce the benefits and strengthen confidence in vaccination. A is for address patient questions and any concerns about the vaccine, including side effects, safety, and vaccine effectiveness in plain and understandable language. R is for remind patients that flu vaccines protect them and their loved ones from serious illness and flu-related complications. And E is for explain the potential costs of getting sick with flu, including serious health consequences, time lost from work or school or family obligations, and of course the financial cost. A link to the SHARE method is provided on the bottom of the slide. How should a provider respond to a parent or caregiver who remains hesitant despite all the strategies we discussed? Although we want to place the majority of our focus on the hesitant population or the fence sitters, you may come across the skeptics, and you should know some strategies to address the situation if that occurs. One approach to handle the situation might be to use the guiding style or motivational interviewing. The goal is to engage the parent in a collaborative working relationship, allowing them to feel involved in the decision to change in a respectful and non-judgmental atmosphere by keeping the door open. Let's see an example of this.
Hi, Mrs. Karen. How are you today?
I'm doing well, thank you. How are you?
I'm doing great. So I'm just looking over Robbie's chart, and it looks like he's doing great and is right on track. Good. So do you mind if we take a moment to talk about Robbie's vaccines?
Sure. I've been doing some reading online, and I'm not really sure how I feel about vaccines. So me and my husband decided that we're not going to vaccinate.
Okay. Well, could we just talk it through so I understand your decision?
Sure.
To start with, can I ask how important is it to you for Robbie to be protected from vaccine-preventable diseases?
I mean, overall, Robbie is a healthy boy. I mean, he eats healthy, he rarely gets sick, and he goes outside a ton, so he gets a lot of exercise and fresh air. So I'm not too concerned about him being exposed to vaccine-preventable diseases, and if he was, I think he would be able to overcome it.
Well, you're right. Most children will overcome illnesses without any problems. However, there are some children who may get very sick and end up being hospitalized. For example, with measles, 1 in 5 people will be hospitalized.
I didn't know that, but I'm still not sure that vaccination is right for us right now.
So, what have you found online, or what have you read?
So I was reading online that vaccines can cause brain damage or other sorts of health-related issues, and that there's pharmacy companies out there that try to cover up some of the issues that happen. And I'm just not really sure about it.
That does sound frightening. And understand your concern about vaccines, but I'd like to give you my point of view, if that's okay. Sure. Vaccines are held at a higher safety standard than most medications. And there's extensive research and testing that is done before a vaccine is even introduced to the market. And, there's continuous monitoring for safety even after the fact. So I vaccinate my own children, and I truly believe in vaccination. So I think it's an important component.
Okay, I mean, that's great, but I'd still like some time to think about vaccination.
Okay. Well, may I give you some materials so you can read it over and think about it some more?
Sure, that'd be great. I'll review it at home.
I do think it's an important issue, like I said before, and I will talk to you about it next time.
As you can see from that example, you wouldn't expect to get a person who refuses all vaccines to vaccinate after just one conversation. Maybe just getting the parent to be open to a vaccine conversation would be your goal. Motivational interviewing is a skill which is beyond the scope of this presentation. However, it is considered to be a promising practice to address vaccine hesitancy. Please refer to the resource listed on the slide for more information. In summary of what we discussed, I want to leave you with some points about what works. Empathy. People want to know that you care before they want to know what you know. Remember to use active listening techniques. Check for understanding. Repeat back what you heard to ensure you are truly hearing the patient's concerns. Acknowledge that vaccines, like medications, do carry some risks. Don't over-reassure. Utilize the presumptive approach. By assuming a presumptive tone, parents are made to feel that getting the vaccines is what most people do, that it is actually the socially accepted norm, and therefore they're less likely to resist. Motivational interview may be beneficial for those who are not ready to make the vaccine decision yet. Make sure you use cultural competency. We haven't touched on this as much, but this is where knowing your audience is crucial. What do they value? Can those values somehow coincide with the acceptance of immunizations? This may involve getting to know your community better or collaborating with outside agencies and stakeholders to help open the lines of communications. And the last item on my list is to use plain language. Avoid medical jargon when discussing vaccinations with patients. For example, instead of saying immunity, say protection from disease. Instead of serology, you could say testing of blood to show if you have protection from diseases. Or use the word harmful instead of adverse. The principles of plain language focus on communication that is clear, concise, and logically organized. It is not dumbing down information, and the tone of communication should not sound condescending. For more information about health literacy in plain language, visit the CDC's Health Literacy Basics webpage noted on the slide. And lastly, you can create a culture of immunization when all staff are involved. Listed on this slide are 10 concrete steps that can easily be implemented into your practice. I now want to move on to the third objective of our presentation, being able to share credible vaccine resources. In order for us to do this, we need to teach our patients to avoid taking things strictly at face value. We know a lot of parents look for information online, so teach them the important questions to ask, such as, who runs this website? Is the information reviewed by experts? Does the site make unbelievable claims? Let's see some examples of this. The following are fake websites used strictly for educational purposes, and I gathered these from Medline's Health Information Tutorial. Your doctor told you, let's suppose, that you have high cholesterol, so you want to learn more about the condition through an internet search. You come across this website, Institute for a Healthier Heart. You view the About Us section to learn more about the organization. It reads, the Institute for a Healthier Heart is run by a select group of individuals and businesses concerned with their heart health. Ask yourself, who are these individuals? Are they even qualified to discuss medical issues? As you dig deeper, you see the mission is to provide the public with health information and offer related services. So what are these other services? Are they free? Once you keep reading, you discover that a company that makes vitamins and medication helps to sponsor the site. You also notice a link for shopping. You see the online store includes items from the drug company that funds the site. This clue suggests that the site might have biased information. Of course, sites can include advertisements, but it should be labeled as such and easily to distinguish from the educational content of the page. In order to contrast to the other websites, this website provides some background data and identifies the source. Information written by others is clearly identified. Maintaining your privacy is another important thing to remember. Some sites ask you to sign up or become a member. Before you do, look for a privacy policy to see how the site will use your personal information. On this example, the website contains a link to the privacy policy on every page. We also see that when the site was last reviewed, to help us to determine if the information is indeed current. These are all important questions to ask when seeking information. The Immunization Action Coalition created the flyer on the slide to help parents find answers to their questions. This is a great resource to share to help parents identify reliable resources. Let's now move on to credible resources. We mentioned earlier that educational materials should supplement but not replace the vaccine conversation. When CDC provides educational materials, they want to make sure they incorporate principles of risk communication. This slide is from the CDC and explains how their materials, training, and information use this approach. They have tips for a less stressful shot visit and tips on how to hold your child during vaccines. These materials were created to empower parents to make the choice to vaccinate. The provider resources for vaccine conversations with parents is also a great CDC resource to use in your practice. All materials are based on research, informed by risk communication principles, and reviewed extensively by subject matter experts. These are some samples of resources for parents. As you see, they are available in different languages and formats, including infographics, posters, and videos. These are all eye-catching and very user-friendly. I want to bring this back to the local level and share some of the New Jersey Department of Health Vaccine Preventable Disease Program materials. We mentioned starting the vaccine conversation early, so you'll see we included a flyer labeled Reliable Resources for Expectant Moms. It can be shared with patients so they know where to access credible resources. Pregnant moms also need to be aware of the importance of the hepatitis B birth dose. So there's an example of a brochure that we have. And preteens and teens need vaccines too. The flyer on the right gives quick tips to providers to help increase immunization rates in this population. The New Jersey Department of Health Vaccine Preventable Disease Program also includes the New Jersey Vaccines for Children program, or VFC. VFC is a federally funded, state-operated vaccine supply program that provides pediatric vaccines from birth through age 18 at no cost to doctors who serve children who might not otherwise be vaccinated because of inability to pay. Not-for-profits, health departments, and federally qualified health centers should also inquire about the 317 funded program for their adult, at-risk, uninsured, underinsured patients. Visit the link at the bottom of the screen and scroll to the bottom of the page regarding enrollment information in VFC and/or 317 programs. The DOH VPDP also houses the New Jersey Immunization Information System, or NJIS, the official statewide immunization registry. NJIS maintains immunization data on New Jersey residents across the lifespan and consolidates immunization information reported from multiple providers into one record. So it provides accurate information for clinical decision support. The goal is to have a robust immunization registry. So to aid in these efforts, New Jersey requires mandatory participation for providers who administer vaccines for children less than 7 years of age. These vaccines should be recorded into the system within 30 days of administration. When using NJIS, take advantage of the reminder recall functionality. This is a newer feature of the system, and as you know, reminder recall is considered to be an evidence-based practice to help increase immunization rates. Finally, here are some additional websites to the New Jersey Department of Health, the New Jersey Immunization Network, which is the statewide immunization coalition, and the CDC, their current immunization schedules. Thank you for participating in today's webinar.
Thank you, Jennifer. So I would like to go to our next page, a couple individuals that we would like to offer some acknowledgement to in helping to develop the program. That is Puthamadam Radhakrishnan, Denise DeYoung, Erica Loeb, and of course, Dr. Paul Offit. Thank you to each of you. I want you to also know that later on today, tomorrow at the very latest, everybody will be receiving a link to the evaluation. Once that evaluation is completed and returned to us, of course, then you will have access to the credits for having participated in today. So we all hope that you enjoyed the program today. We have a couple of minutes left to answer questions, should there be any. And on this last page, of course, is all the contact information so that if you want to drop us a line or have questions, you can reach each one of us. We will look to the questions. Okay, so at this time, there are no questions that are in front of I'm sorry, we're just, thank you. A question just came in. Can we get a presentation? Again, as mentioned in the beginning of the presentation, a copy of the entire presentation will be available on the New Jersey Immunization Network website, and everybody who even registered for the event itself will receive that link as soon as that is available. Okay, so I think that covers any questions. If there are things that come to mind after the fact, you want to send it to any one of the 4 individuals listed on that, please feel free to do so. And again, thank you for attending today's webinar.